Good afternoon, all. So, welcome to the ultimate showdown of wit and wisdom, the ophthalmic debate. Agree to disagree. And our fierce Evas are ready to duke it over the latest ophthalmic controversies. So, sit back and relax and enjoy the spectacle. So, as chairpersons, I would like to call our esteemed chairpersons, Dr. Mohammad Yasin sir and Dr. Shubhashish Nag. Sir, please come forward and take your seats. And I would like to call upon the panelists, Dr. Rajesh Mojumdar Choudhury, Dr. Shubhra Seal, and Dr. Tanmaya Biswas. And I would hand over to Anuradha for telling the rules. And for a change, she is my co-moderator instead of my co-debater. Thanks to Swati. Thank you. Over to Anuradha.
So we will be starting our exciting session. Please wake up from sleep and we are starting a very interesting session. I will call up, the rules of the game are simple. You have to fight within 2 minutes. That's the rule. You don't have a rebuttal here. We would have a discussion from the panelists instead. I would call upon Dr. Nibedita Das and Dr. Piali Konar for the first talk. Okay.
Very good morning. I would like to thank Ophthaeva for giving me this opportunity. I am talking for the session of use of steroids in acute adenoviral conjunctivitis. I am Dr. Piali Konar. We all know that the virus binds to host cell, replicates and triggers an immune response causing inflammation. Now this inflammation, if not treated, can lead to formation of pseudomembrane and corneal infiltration, which in turn will result in scarring and potential vision loss. In the current management strategies, we have non-pharmacological interventions like hygiene measures, use of artificial tears, cold compress, and steroids. Steroids play a very important role by reducing inflammation and immune response, thereby potentially reducing symptoms and preventing long-term complications like scarring. They are indicated in cases with severe with chemosis and lid swelling. Now, what are the benefits of steroid therapy? As we can see, this patient is very upset. He has swollen red eyes and he is not happy at all. So, steroid, first of all, they provide symptomatic relief by reducing inflammation. They alleviate symptoms like redness, swelling, and discomfort. They also help in speeding up recovery. Studies indicate that steroids can expedite resolution of symptoms and improve patient comfort compared to placebo and no treatment. In this study, we can see clearly that corneal infiltrates fail to appear while on steroid therapy in a significant number of patients when compared to placebo drops. Similarly, they help in prevention of complications by reducing inflammation and preventing pseudomembrane formation and corneal involvement. And lastly but not the least, it provides enhanced patient comfort by improved quality of life of patients, allowing them to return to normal activities sooner. We all like a happy patients like this, don't we? We also have clinical evidence to support this. This I have already discussed. Again, in this study of management of adenoviral keratoconjunctivitis, it clearly mentions that subepithelial infiltrate in the cornea is a hallmark feature of corneal involvement. And SEIs have a tendency to recur and may lead to long-term visual disability. Hence, a combination of povidone-iodine and dexamethasone ophthalmic solution has shown favorable outcome. However, this is still in clinical trial and is
Your
not
time
available.
is up.
Not available, just one more slide, ma'am. And we also have the adenovirus ocular manifestation. This study also clearly mentions that patients with pseudomembrane and those with corneal involvement, they benefit from steroid use. So we have to assess the patient profile and we have to balance between immediate symptomatic relief and long-term goals of preventing complications such as scarring and vision loss. And finally, we want our patients to be happy and come back to us rather than like this patient with red eyes going around to all the doctors because they are not happy. Thank you.
Thank you so much.
So now to Dr. Nibedita Das, she would be saying against the motion. So you were saying that it is giving increased comfort, patient comfort, that is most important for you, right?
Not just patient comfort, ma'am. It also prevents long-term complications like development of pseudomembranes and if there is corneal involvement. If you don't give steroid, then this can lead to potential vision loss due to corneal scarring.
So let's see what the against the motion says.
Okay, your time starts now.
Okay.
Yeah, you can start.
Yeah. Thank you, PLE, for giving the steroids for this topic. But we all know it is, yes, it is really challenging the EKC. So as there is corneal involvement in 80% of the cases, it leads to SPK, focal PE key, subepithelial infiltrates, etc. And subepithelial may be very disabling. Usually it arises into 1 to 3 weeks after the acute phase. And there are antigen and lymphocytic accumulations. They adhere to the corneal stromal cell. And the main problem is that they persist for months or years and decreases vision. And most of the clinicians use topical steroids at the first instance to charge the steroids as they prevent the ACI according to them. But it is seen that ACI often resolves without any scarring or corneal neovascularization. So appeal to start steroids usually comes from the concept that it can control the acute inflammation with associated symptomatic relief, and some says that it delays or prevents the visual disturbances by subepithelial immune infiltrates. But it has seen that the pathomechanisms of adenoviral infection that they causes lysis of the microepithelial cells of the conjunctiva and surface, and they also causes latent infection, which is very important in the lymphoid and adenoid cell. The interleukin, they secrete interleukin from the epithelial cells, and that eventually leads to internalizations and replications of the virus in the corneal stroma. And topical steroids, what does they do? That they reduces the viral clearance by the immune mechanism systems of the patient's own body, and they prolong the viral shedding. And also they reactivate the persistent latent adenoviral infections in the host cell by blocking the antiviral activity of the interferon, maybe over the years. Leibson et al., they have also shown that they increases the disabling ACI when steroids used early. And as the steroid increases the antigen loads by increasing the viral replication.
Time is over. Okay.
Okay.
Please make it fast.
17 to 15% of the recurrence rate also occurs, and they lead to unsuccessful drug tapering. So abrupt discontinuance also causes more appearance of more ACI. Even short-term treatment with a mild topical steroid may also delay the viral clearance. And also one important factor is that adenoviral conjunctivitis is great mimickers. Around 3 to 5% of the HSV also mimics adenoviral keratitis, and some other host-cyclic virus, enterovirus, and other non-viral infection also mimics. So they prevent inadvertent use of steroids that may cause the flare-up of infection. So I'm concluding.
Okay. Thank you. Thank you so much. Very well presented, both of you. Over to our esteemed panelist, Dr. Yasin sir. So would you like to add some comments?
After 2-3 days, the patient will come back saying that lal to gelo na, kosto to hocche. That is very irritating for me and embarrassing for me. So I would like to use steroids.
Okay. Thank you, sir. Shubhashish sir, would you like to say something?
Okay. Basically, the second speaker had some important 2 points. Early steroids, and at the end she wrote something about medico-legal issues. Well, I, as you all know, I'm a solo practitioner. I tell my patients, you need to use this drop after 5-7 days. So steroids after 7 days,
Yes.
because it takes 2 weeks usually otherwise. So that is my take on that.
Yes, sir. Thank you.
So
I think
show of hands for giving steroids early, after 7 days. Most of us would like to do. Yes. So thank you very much. Going over to the next topic, it is the oculoplasty. And our own Dr. Shobhita Katoch ma'am will tell us about facial aesthetics, a boon for us for the motion.
I think this is the talk of the town now. We all Evas are very interested in listening to her.
Yes, nice to hear that. Given the same topic 2-3 years ago, I would have fought hard to be on the other side. I would have said, यार मैं डॉक्टर बनी हूँ सिख लोगों के लिए, हाँ? I don't want to cater to the whims and fancies of some, spoilt, wealthy women. And look at me now. And things are changing. I think we all would aspire to have lovely long hair, flawless skin, sharp nose. Men folk not to be left behind, sharp jaw, aquiline nose, no wrinkles. So why us? Dermatologists do it, dentists do it. As oculoplasty people with a periocular focus, I think we are best suited for this work. Why aesthetics at all? It's a 8.1 billion US dollar market in India. Just to give you a reference, the ophthalmic devices is a 0.7 billion US dollar market presently. Social media is very much a part of our lives now, whether you like it or not. Young people want proactive self-care. They want to do things which are right for them, and preventative aesthetics is one of them. They have rising incomes, and there is something called democratization of beauty standards, which basically, what I mean to say, that even a person staying in a small town in India can also have access to all these aesthetics. I mean, earlier it was like a very restricted access, aesthetics meant only actors and actresses, but now everybody wants it. So far, we have done so much to get rid of glasses. We've done contact lenses, ICL, LASIK, multifocals. Look at the R&D going in multifocals. We have been straightening the eyes so long. Strabismology has such a big part in ophthalmology. So once you uncover the face, it has also got to look good. I'm sure all of you will agree.
Savita Di, though we would like to hear more and more, but your time is over.
Okay,
so very fast.
Just a word of caution for unrealistic expectations. You have to give chair time. If this is what I can do to a patient, this picture is courtesy Allergan, I would consider myself a good doctor. Thank you.
Just wow. Thank you.
A very good afternoon to the august gathering here. I would like to thank Tulika ma'am and Dr. Swati ma'am for providing me this podium. So I am the villain here. I'll be speaking against facial aesthetics. Eyes is said to be the mirror to one's soul, but hell bends loose when there is anything going wrong with the look of one's eyes. So we need to decide and introspect whether it's a blessing or a curse in disguise. This is the statistics of America. India has been more acceptable towards all forms of shapes and sizes. Rather, fuller was considered beauty in ancient times, but trend has been changing. This is the perfect score or the golden ratio. But why? Why do we need to have the perfect score always? This is leading many youngsters with the new generation into Reels, going into Twitter and Facebook. There is a lot of body shaming, face shaming, leading them to the doorstep of psychiatrists. Actually, we are increasing their practice in a way. So it's time that we stop looking ourselves through their eyes. Apart from the minor side effects, there has been known to have been serious side effects of CRAO, CVA, and this study actually was saying certain religion disallows the practice of cosmetic surgery. Many a times, FDA-approved products are not being used. The technique of injection is not being done by expert practitioners, leading to inadvertent injections into the blood vessels. Even counterfeit products in terms of botulinum toxin are rampant in the market, leading people to legalities. So I'll summarize the talk. It is always unwarranted and needless, as I might say, expensive. The patients are living in a bubble of unrealistic expectations, which we might not ever be able to fulfill, and ultimately leading them to an addiction of cosmetic surgery, let alone the legalities. The healing time often varies, and finally, nobody can be made perfect. Well-being should not depend on the look. Beauty lies in the eyes of the beholder. Thank you.
Thank you. Very well said and in time. Okay, for this, I think no one better than Rajestha commenting.
Thank you so much. Like everything else in life, the truth lies somewhere in between. Both the ladies spoke very eloquently. If you ask me, the one very important point which Savita mentioned is the democratization of the standards. But unfortunately, there is no democratization of access or democratization of resource. So basically what happens is, I'm just going to mention one point. I know you people are waiting for lunch. What I'm going to mention is, you have this very, superlative standards of beauty going all around, and that is being accessed by a young girl from Jumri Talaya or a young boy from Kuch Bihar. Do they have the access to take recourse to this kind of treatment? So that is a basic point. Saying that, as oculoplasty surgeon, whatever we do, that has to match a certain level of aesthetics. When you do entropion surgery, you cannot afford to make the patient look worse than he was before. So I think we have to maintain that idea that we have to do everything with the aesthetics in mind. At the same time, when you're doing aesthetics, even pure aesthetics service, the control should be in the hand of the clinician, not in the hands of the patient. So you should be in charge, not them. That's my take. Thank you.
Thank you. Shubhra ma'am, would you like to say something?
Well, previously it was only the film stars who used to use those Botox fillers and all. Now it's the common people are also opting for all these things. So I think a little more training in this cosmetology, facial aesthetics, very important to bring it down to the PG level. So let them learn from there. We have, Shovita Di, myself and few others, we had attended facial aesthetics workshops at SN Chennai and all. So I think training will, I think with better training, we will be able to give better service to the patients.
Thank you, ma'am. Swati, would you like to go for facial aesthetics in the future? Now you don't need it at all, but maybe after 10, 15 years.
Yeah, definitely I would go for it. Okay. And who knows, I'm still using it.
Okay, so over to...
Next topic, the most exciting in pediatrics, whether to give a IOL in a 6-month-old child or lesser. Smita is in favor. She is starting now.
Good afternoon, everyone. So today is, should I implant an IOL in an infant 6 months or less? What the IATS told us, it told us that if you are implanting an IOL at less than 6 months, there are more complications at the end of 1 year, and it will lead to more resurgeries. But then again, when we are in a country like India, we find that aphakia is a causes dense amblyopia, and it has poor compliance to occlusion therapy. The risk of glaucoma, RD, endops increases with aphakia. Patients are often lost to follow-up due to poor economic status and lack of accessibility. There are hyperopic glasses are expensive, undergo wear and tear, where contact lenses are poor hygiene and acceptability. The cost of a primary IOL plus minus a membranectomy is lesser in developing countries than developed ones. And secondary IOL implantation will have its additional risk as well as cost. So, some real-world data from this side. If you are implanting an IOL even in less than 6 months old, in the back, the overall complication rate was found to be less by the study by Nagalur et al. And resurgery rates were also less. Though VA would still remain the cause, it was not significantly related to age. Whereas Chettenever et al. Found that in pseudophakic patients, VA was still the main complication, whereas secondary glaucoma, endoff, and vitreous hemorrhage were the complications which was found in aphakics. So, they concluded VAO can be reduced with in-the-back IOL, good cortical cleanup and anterior vitrectomy, hydrophobic acrylic IOL, and intense post-op steroid regime. When we come to glaucoma, we see that the Asians are much more affected in congenital cataract cases than the Europeans, and IOL implantation has a definite protective effect. Lower age of surgery, however, is a definite risk. So, the study by Chogole and Kekonia found that if we compare between IATS and the data from developing countries, what we come to the conclusion is that both complication rate as resurgery was lower in the IOL group in our data than IATS, better visual outcomes for dense unilateral or bilateral cataracts, aphakia increasing risk of sight-threatening complications, secondary IOL having difficulty in the back.
Your time is over. Please
okay,
be
this
fast.
is the last slide. So the final conclusion is, choose a trained surgeon, consider the socio-economic modality, and most important, Choose the I. Absence of angle dysgenesis or corneal opacity or raised IOP, minimum corneal diameter of more than 10.5 and axial length of more than 18, adequate capsular support and preferably in the back placement and aggressive post-op steroid regime.
So over to you, Achal Mitra. So Smita was saying that we should not leave the child aphakic because the amblyopia is dense. You can have glaucoma and it is better to give a IOL and look after the complications, right?
Okay, you can start now.
Yeah, good afternoon everybody. So I am against my debate topic and that is pseudophakia in infants less than 6 months. So I'll start enlisting my basic reasons. The most basic of all, the IOL calculation in such small eyes with steep K values are most often than not incorrect and thus it can in future lead to large refractive errors and a need for IOL exchange. In the same lines, there is an unpredictable myopic shift in less than 2 years of age, which can further give the unexpected refractive errors to the surgeon and can lead to an IOL exchange in the future. Many studies have corroborated the fact that the post-operative adverse events like pupillary membrane, post-operative inflammation, posterior capsule opacification is more in the age group of 6 months or less when implanted with an IOL as a primary IOL implantation. So there was a very interesting study by Solano M under IATS which says that there is an increased parental stress, more hospital visits and an increased need for care and compliance in cases of primary implantation, IOL implantation in less than 7 months. So also lastly, the major reason is the largest randomized control study which is IATS in less than 7 months of age for unilateral congenital cataracts. They say that the visual outcome in short term and long term with contact lenses is similar to the primary IOL implantation. Also for bilateral congenital cataracts, there are many studies which say that visual outcome with aphakic glasses is similar to the primary IOL implantation. Also, according to me, the primary IOL implantation is a more skillful procedure in less than 6 months of age. So it's an absolute no from my side. I will like to conclude my debate by saying that, which was a very popular saying in my fellowship, and that was a good aphakia is always better than a bad pseudophakia.
Thank you so much and well in time.
So we would ask Tanmay for his comments.
So as of now, I am personally not implanting IOL in less than 6 months of age. The main problem is that the power of the IOL, the biometry, because even with significant undercorrection, they will still end up with very high myopia and all. I do remember a patient who was 8 months old during my fellowship days, and the biometry emmetropia power was showing as plus 50. But the highest available power that was available plus 34 that was implanted, then it should have been something around plus 10, plus 12. But after implanting that IOL, the refraction came as retinoscopic value was plus 2. So within 1 year, the patient went from plus 2 to minus 6 at the age of 1.5 years of age. So this patient will end up with minus 20 or something like that and will need an IOL exchange. So less than 6 months of age. As of now, I'm not implanting IOL, and most of the consensus is aphakia, and above 6, it is usually the ages for IOL implantation is reducing by the day. So as from my side, it is a no for less than 6 months of age.
Is your threshold lower when it is a unilateral cataract?
That depends upon the axial length and the corneal size and all.
Ma'am, Shubhra ma'am, would you like to add something?
From my side also, a big no for doing IOL, implanting IOL below 6 months.
Yes.
We'll do a good cataract extraction and take care of the amblyopia therapy. It's very difficult. Once amblyopia sets in, very difficult. You can take care of the myopic shift, give some refractive error correction, that is easy. So I'll take care that a good aphakia with refractive correction and amblyopia therapy, and then I'll go for a secondary IOL.
Okay, ma'am. Ma'am, would you like to say something?
6 months to 1 year.
6 months to 1 year, I think unilateral we would go for a IOL. I think so. That would be.
Axial length is very important.
If I can make a quick comment, I think everybody said very rightly that it's not just the age. First criteria is the corneal diameter, because anything less than 10 millimeter for me now, it used to be 9.5, do not implant an IOL. Second important point, you should be experienced enough of doing a good vitrectomy, putting a good in-the-bag lens in older children. Then only you move to implantation in below 6 months. And third thing, if you cannot put hydrophobic acrylic IOL in the bag, whether it's 3-piece or 1-piece, then please abandon it. And like was pointed out in the debate, that we live in a country where all these, it sounds nice to say that give good aphakia and good amblyopia therapy, but how many actually come back and are those who cannot even put glasses, are they going to do all the patching and follow-ups? So in some ways it makes sense to put an IOL so that at least there is some partial visual rehabilitation. I agree that there will be myopic shifts and all, but the key point is you should be able to technically very, very confident. And second thing is follow-ups. If you think you cannot follow up, even if you do a free checkup or repeated EUAs, if you cannot follow up, please don't put an IOL, because a VAO is one of the most common problems. As far as the glaucoma thing goes, I think there is so much mixed evidence. I personally feel, and I think a lot of literature, I am sure the experts will agree, that I think IOL or no IOL is not the main reason for glaucoma. It's the age at surgery.
Anuradha, please do add some points.
So, like we were discussing, it is the corneal diameter and the axial length of the eye that would help us. If it is unilateral, I would likely go earlier in and put a IOL. If it is bilateral, you can still wait, because we are putting glasses in both the eyes, and those amblyopias are easier to correct. But by 1.5 years, I would like to put a IOL in if I have left aphakic. So moving on to the next topic, single cranial nerve palsy, neuroimaging is mandatory for all. For the motion is Dr. Ritu Gatia.
Okay, your time starts now.
Good afternoon. For all single cranial nerve palsy, neuroimaging is mandatory. As we know, since the development of MRI, there are less benign and potentially treatable causes which can be identified, documented with the help of MRI. And over the last 2 decades, there have been major advances in the treatment of neurological conditions, thus making early diagnosis important in our clinics. Literature shows the diagnostic yield of neuroimaging in headache is just 1.5%, yet we do it and we don't debate. In the patient with cranial nerve palsy with age more than 50 years, the yield has been shown to be 16.5%. In this review article, it has been stressed that contrast-enhanced MRI must be done for all patients, irrespective of their age group. In child and adolescent, this is we will miss serious pathologies. In young adults, also there are serious pathologies for the cranial nerve palsy, and we must do the neuroimaging. We can debate about the patient's age more than 50 years, where we have vascular risk factors. In those cases also, if we do MRI, and we can find important pathologies like neoplasm, GCA, brainstem infarction. When compared to neurologists, ophthalmologists are the one who are doing triage about the imaging. Neurologists are likely to perform MRI scanning in every patient, and they are the one who will be treating all the cranial nerve palsy when we send them for neurological opinion. In the modern era of medicine, prompt initiation of antiplatelet therapy or anticoagulation, or in immediate evaluation and control of blood pressure in the setting of hypertensive hemorrhage, these are the interventions that can be instituted once the neuroimaging identifies such lesion. One should not miss a single case of potentially fatal event. We may fail to elicit important history or miss important findings at times. Medico-legally also, we must prescribe the proper test. Hence, proper neuroimaging for all the patients presenting with single cranial nerve palsy, irrespective of their age group.
Thank you. And against the motion is Dr. Nazneen.
Good afternoon. In the beginning, I'd like to admit that I would like to do neuroimaging for all patients, but I'm here to speak against the motion. So,
To prove it.
to be safe and to avoid myself landing into medical legal trouble. Anyway, so single cranial nerve palsies are caused by a wide range of diseases, and neuroimaging plays a critical role in determining the etiology and planning treatment. However, what is of paramount importance is the patient's history and clinical examination. We know the MRI is the gold standard for such cranial nerve palsies. However, the traditional teaching in neurophthalmology is that patients with isolated oculomotor neuropathies, mononeuropathies, and those who have microvascular risk factors, they may be followed up without immediately going for neuroimaging. I would like to reserve neuroimaging for patients less than 50 years who have presence of in whom I know there's a vasculopathic risk factor, who have history of cancer, there's a worsening diplopia and no improvement in the palsy over 3 to 6 months, who have multiple cranial nerve palsy, and who have other neurological features. The disadvantages of neuroimaging for all is that the diagnostic yield in patients in whom I know a vasculopathic risk factor is present is low, and definitely it is costly. Now, this was a study that was published in Archives of Ophthalmology. They studied 93 patients of mononeuropathy. In them, only one had MRI findings relevant to the mononeuropathy. And to find that one patient, and the finding did not even alter the treatment plan, 0.13 million US dollars was spent to do MRI on those 93 patients. It may not be medically necessary, therefore, to perform MRI in all. So clinical history and examination and clinical judgment are of utmost importance. MRI definitely has a role. However, picking up a neurological lesion in a few must be weighed against the cost and logistics of ordering sophisticated neuroimaging in all patients. Thank you.
Thank you.
So, the most important topic, because it has a very much importance in medical legal sense, in which cases you wouldn't like to do a neuroimaging. I think that should be summarized.
You asked me in which cases I would not like to do. Yeah. See, facial palsy cases where there is history of exposure to cold, or exposure ENT problem, those cases I would not like to do. Otherwise, normally I do.
During our PG, what we were told is third nerve palsy. Wait for some time. If your pupil is okay, no RAPD, color vision is okay, your optic nerve, there is no papilledema or something like that, you can wait a little bit, but not. Najneen has rightly pointed out 3 months. So during our PG also we were taught 3 months. If it does not really, we will, yes. Stop, yeah.
For me, I would probably, I think again, is a vasculopath patient and no headache, and if it's responding, it's improving, then no neuroimaging. But if it's not, the other way around, then of course.
What I usually follow is, if I'm not imaging, I usually call back the patient every 2 weeks. If there is no development of additional features, if there is improvement, then we can wait. Otherwise, if the patient is not able to follow up, definitely image. But third nerve palsy, I definitely go ahead and image. Only fourth nerve and sixth nerve, we can wait, but I do call the patient every 2 weeks.
So we have come to end of our session.
With that we conclude, but before that I think we have to move over to the awards, and we have to give the awards. And a group photo. So I would like to call upon the esteemed chairpersons, the panelists, the speakers, and us, the moderators.
Requesting the chairpersons to please hand the gifts to our moderators, Dr. Anuradha, Dr. Rituparna, who did a fabulous job making the session a cat's fight, but women now are smart enough to agree not to disagree. Calling Dr. Piali Konar, Dr. Nibedita Das, please come forward. Dr. Sabita Katoch, Madam, Dr. Shripurna Ghosh. Dr. Smita Ghosh, Dr. Aanchal Mitra. Dr. Ritu Garia. Dr. Nazneen Nazm. Dr. Ritu. Dr. Ritu Garia. Dr. Nazneen. Would request the chairperson to give it to the esteemed panelist, Dr. Rajesh Majumdar Chaudhary next. Dr. Shubhra Seal. Dr. Tanmay Bishwas. Dr. Debashish Datto. Requesting Dr. Debashish Datto, sir, please come forward and honor the chairpersons for the session. For Dr. Yasin, sir, who recently also got an award for the best doctor at IMA. Dr. Shubhashish Nag, sir. Thank you, everyone. Now is the time for none other than, yes, ...